This video was created to serve as evidence of clinical learning. Its intent is to act as a platform for me to share one of my nursing assistant experiences while highlighting the importance of being knowledgeable and sensitive towards psychiatric care when working as a nurse on the general medical surgical unit. Upon starting my day shift, I arrived on my unit and sought out my assignment. To my surprise, I was assigned to be the sitter in a one-to-one. Before entering the room, I checked in with the assigned nurse for a report. While having to practically beg the nurse to give me a moment of her attention, I asked if there was anything I needed to know. The nurse fired back that she was a psych patient from an addiction rehab facility. I asked her why she had to sit there, and she responded with, "Because she's a psych patient." I relieved the previous sitter from the night before, and I thought to myself, at least half of the patients on this floor probably have some type of mental illness. Is she a suicide risk? A risk for using while in the hospital? A flight risk? None of these things were true. The patient was assigned to sitter simply because of her psychiatric history, when no actual safety concern or disruption to the unit was present. I entered the room to find the patient hiding under the blankets sleeping. The patient did not make a sound until breakfast was delivered, and at this point I woke her up and checked her vital signs. Upon wakening, the patient was confused, lethargic, repetitive, and extremely upset. The nurse did not come see the patient until morning med pass. The nurse did not explain what any of the PO medications were or what they were for, and handed the patient the med cup saying, "Here." Throughout the remainder of the day, the nurse never assessed the patient physically or psychologically. The patient remained confused, repetitive, with crying outbursts, but never left the bed except to get washed up. To myself, I thought, this patient could have not been assigned a nurse, and it would not have made that much of a difference. A different nurse changed that patient's IV solution after I had asked someone to come in and silence the alarm. I was then feeling that maybe the nurse was very busy with her other patients who were more acutely ill, but when I continuously looked into the hall, I saw the nurse sitting at the front of the nurse's station chatting with the secretary every time. The patient had been trying to contact someone during the duration of her admission with no luck. I continued to help the patient call the numbers she had from memory with no answer until finally her mom picked up. Her mom had no idea what had happened, and when I went to retrieve the nurse to explain the situation and update her mom, I had to practically peel her off the seat at the front desk. The nurse did not know enough about the reason for admission or even care to assist the patient and her family during this difficult time. After the nurse's extremely brief exchange with the mother, the patient continued to cry and rant that the previous facility she was at was hurting her and not giving her good care. The story about how my patient initially was admitted was very fuzzy. Upon reading limited info in the chart, the facility she was at called an ambulance because she was found unarousable. The nurse did not even know this, nor share this information with the mother. The patient was so hysterical she was not able to verbalize anything to her mother. The patient did not remember what had happened and did not know why she was in the hospital. I felt horrible for the patient, and she continued to lie there helpless when I left for the end of my shift. If this very same situation happened again, I would have liked to advocate for my patient by speaking with the nurse directly and how I wasn't comfortable with the way she handled the patient's family and the patient, or notifying a higher authority. Although I felt like all I did the entire shift was attempt to advocate for the patient, my involvement was not enough to give the patient the care and respect she deserved. In my practice, I will incorporate the communication techniques I gained through being involved in simulation lab and attending clinical each week. During these experiences in the semester, I learned how to effectively use therapeutic communication in patients with mental illness. In my practice, I will not neglect patients with mental illness or associate a stigma with them. In my practice, I will use therapeutic communication to assist patients in working through difficult times, in acknowledging their illness, and understanding how they got where they are, and how we can, together, get them to where they want to be. If this situation happened again, I would have used therapeutic communication as a CNA to calm the patient down and assist them in understanding what exactly she was doing in the hospital. Similarly, an article parallels the clinical learning that took place that day. Available in the Journal of Interprofessional Care, the article highlights the presence of mental illness stigma as a common problem in healthcare students and professionals. The article goes on to discuss how this stigma is associated with numerous negative outcomes, as I saw firsthand with my patient that day. Interprofessional education is offered as a solution to raising awareness of this issue and erasing these attitudes specifically in the hospital setting. In conclusion, the patient was not properly assessed, informed, or updated about her plan of care. The nurse chose to assign a label to my patient and neglect her for the entire shift. In the future, I will be sure to respect patients with mental illness, even if they are in the context of me caring for other patients who do not suffer from mental illness. I will also incorporate therapeutic communication with all patients and consistently provide the care every human being deserves, regardless of their history and diagnoses.